Hello everyone, my name is Hilary Michael, and today we'll be talking about pediatric inflammatory bowel disease, focusing on background and diagnosis. The objectives of today's lesson will be to review some basics of IBD, understand the differential diagnosis, and discuss the diagnostic workup for pediatric IBD. So to begin, what is inflammatory bowel disease? Well, actually, it's a combination of chronic inflammatory bowel diseases that mainly affect the GI tract, and typically is broken down into two main categories, Crohn's disease and ulcerative colitis. The third category there, IBD unspecified, exists for the patients that don't fall super nicely into one category or the other. IBD is pretty common in the United States, anywhere from 100 to 200 per 100,000 is the prevalence. And important to know that it's most commonly diagnosed between 15 and 40 years of age, and up to a quarter of patients are diagnosed in their pediatric or adolescent years. What causes IBD? That's the million-dollar question. And in reality, it's probably a combination of things. We know that genes play a role, with hundreds of genetic loci being associated with IBD. We also know that environmental triggers play a role, things like food additives or infections. The microbiome plays a role, meaning the bacterial makeup inside the gut. And then finally, there's an inappropriate immune response in patients where the immune system is overactive, leading to inflammatory bowel disease. Now, between the two types, Crohn's disease and ulcerative colitis, there are particular characteristics. Crohn's disease is characterized by deep inflammation. It can affect anywhere in the GI tract from the mouth to the anus. It can be patchy with intervening pieces of healthy bowel, and it can be complicated by things like strictures, abscesses, and fistulae. Ulcerative colitis, on the other hand, is characterized by more superficial inflammation just on the mucosa or lining of the gut, and it classically starts at the rectum and continues proximally around the colon. Crohn's disease can also have different behaviors. So some patients with Crohn's disease have inflammatory Crohn's, where the bowel wall gets thickened and inflamed. Some have stricturing Crohn's disease, where scar tissue forms and stenotic areas develop. And some have penetrating Crohn's disease, where fistula or abnormal connections will form between two loops of bowel, or even between the bowel and other organs or parts of the body. And before we get into how we diagnose Crohn's disease and ulcerative colitis, I want to highlight a few places where pediatric IBD is unique. First of all, children are at risk for having more extensive inflammation and more severe disease. And also, they can present very young with something called very early onset IBD. This is diagnosed at less than 6 years of age, and it's an important subset to know about because pediatric IBD diagnosed young can be associated with immunodeficiencies, and these very young children are more likely to have a single gene mutation that causes their disease, severe disease, and disease that fails conventional treatments. So let's get into diagnosis. First, you got to take a great history, and that begins with GI symptoms. When you talk about abdominal pain, you want to know about the location, the duration of pain, and the pattern. What makes it worse? What makes it better? We always want to know a really good stooling history, and so we want to know how often patients are having bowel movements, what they're like. Are they loose? Are they formed? If they have any blood with them, and if they're waking up at night to have bowel movements. Now, importantly, IBD can show up with non-GI symptoms as well. And so some highlights to focus on include any fevers, weight loss, rashes, or joint symptoms. You also want to ask about exposures. What have they been eating? Have they had any fresh water exposure? Any animal exposure, specifically reptiles? Any travel and any recent medications, especially antibiotics. And then finally, you want to ask about family history. Does anyone else in the family have inflammatory bowel disease, other GI illnesses, or other autoimmune diseases? The next step, of course, is an excellent physical exam, beginning with your vital signs. And things to look out for include tachycardia or fever, which could tell us maybe that the patient has a complication of Crohn's disease, like an abscess, or maybe anemia associated with GI blood loss. The next thing that is essential to look at are the patient's growth curves. Patients with weight loss or poor weight gain or height gain may be showing up with inflammatory bowel disease, and that could be their only finding. Then as we move down, you want to check out their head and neck, look at their oral mucosa. Is there pallor to indicate they might have anemia? Are there any aphthous ulcers like the one you can see in that photo there? That can be a finding with Crohn's disease. On the abdominal exam, look out for belly tenderness, any rebound or guarding, and sometimes masses can be palpated just from the inflammatory component of the disease. A genitourinary exam to look at pubertal development is really important as well. Sometimes pubertal delay is the only way that kids with Crohn's disease show up. A perianal exam is essential, looking for skin tags, fissures, or abscesses. Extremities can be important too. Look out for joint pain or swelling, or sometimes digital clubbing, like you can see in the photo there. And then a good dermatologic exam looking for rashes is important. Erythema nodosum can show up typically on the shins, and it's a kind of a bruised appearance, very tender. Pyoderma gangrenosum is also associated with IBD and has this ulcerated look, as you can see in the photo. So before we get into trying to test for IBD, it's important to build that differential diagnosis. One of the highest things on the differential should be a GI infection, bacterial, viral, or parasitic. Irritable bowel syndrome is also there in your differential, so things like IBS or other functional GI disorders. Celiac disease, appendicitis plus or minus appendiceal rupture and abscess formation. Other immune-mediated bowel diseases or immunodeficiencies like we talked about with very early onset IBD. And then finally, primary rheumatologic or endocrine disorders that can show up with growth or pubertal failure. Next, we want to get some labs and stool studies. And the classic labs you want to go to include CBC to look at blood counts, CMP, especially focusing on an albumin level, which can be a negative acute phase reactant, inflammatory markers with a SED rate and CRP, celiac screening. For most kids, that's going to be a total IgA and a TTG IgA, and then thyroid function screening, especially if they have any growth or pubertal delay. From a stool testing standpoint, you want to get a C. difficile test, stool culture, ova and parasites, and a stool calprotectin to look for inflammation. If those labs are concerning for IBD, your next steps will be to talk to your friendly gastroenterologist and get upper and lower endoscopies scheduled. And why do we get these? Well, first of all, we're looking for a distribution of disease, which can help us determine if this is Crohn's disease or ulcerative colitis. We want to see the severity of disease, which helps us choose a therapy. And again, we want to try to figure out which disease does this patient have. So here are a few pictures of normal endoscopies. The top three from left to right show a normal esophagus, stomach, and small intestine, duodenum. And the lower three show three different segments of the colon, which all look normal. Nice, light pink mucosa with easily visible blood vessels. Now, what would a colonoscopy look like with Crohn's disease? On the far left, you can see some small bowel mucosa with some ulcers. And then the middle photo shows these deep ulcers that are patchy with a little bit of normal tissue down there at the bottom. The far right photo shows some severe ulceration with deep linear ulcers and overlying purulent exudate. These all look classic for Crohn's disease. Ulcerative colitis, on the other hand, if you remember, is limited to the mucosa, to the surface, and tends to be more continuous. So the top left photo is actually normal, but then as you move to the top right, and then the bottom two photos, you can see examples of progressively worsening ulcerative colitis with redness, loss of vascular markings, some punctate areas of bleeding, and even some purulent exudate as well. Histologically, and this is another important part to make the diagnosis for IBD, For both Crohn's and UC, you may see crypt branching and atrophy, and that's what you can see there, that branching of the crypt, which tells us that there's chronic damage going on. Crypt abscesses, which you can see with this second picture and the arrow, which is really just a collection of white blood cells and inflammatory cells inside of crypts. Then for Crohn's disease specifically, if you recall, you might see discontinuous transmural inflammation, so inflammation that goes deep through the wall of the bowel, and granulomas, which are pathognomonic for IBD, and you can see that there in the circle, specifically for Crohn's disease. Now for ulcerative colitis, the main thing that the pathologist might comment on would be a more diffuse, uniform inflammation. And then last but not least, to diagnose IBD, we want to get imaging. And the reason for this is, first, we want to evaluate the small bowel because our scopes only go so far, both from above and from below. And second, we want to assess for complications. This is especially important for Crohn's disease, where we want to worry about abscesses, fistulae, and strictures or narrowings. So the main way we do that is with something called an enterography. There's both a CT enterography and an MR enterography, which are special CT and MRI scans with oral contrast and IV contrast that really help to highlight the small bowel. For both of these, you can see the arrows pointing to thickened, enhancing small bowel that tells us that there's inflammation there. Now, you may also hear about capsule endoscopy, and sometimes these are used where patients can either swallow this capsule or it can be placed with a scope, and the capsule takes photos throughout the small bowel as it travels through the gut. This is not always essential, but can sometimes be a helpful tool. And so there you have it. To take home today, I want you to remember that the common symptoms of IBD include abdominal pain, diarrhea, rectal bleeding, and weight loss. But don't forget about those extraintestinal symptoms, and especially in pediatric IBD, think about this disease when you see kids with growth failure or pubertal delay. And a complete diagnosis of IBD includes a good history and physical, endoscopy, histology, and radiographic workup with MR enterography or CT enterography. And that's it. Thanks so much.